And it's a real pleasure to invite my wonderful colleague, Dr. Nina Parker, who's here with us to talk and really to allow us time to discuss a bit more about what she presented earlier in the Congress regarding the psychological and emotional impact of pregnancy loss. And I guess the first real question for us, Nina, is what is the scope of this problem? And what do we know about really the estimated incidence of miscarriage and as a result the incidence of emotional and mental impact on mental well-being?
So I think we're now estimating that 15 to 20% of all pregnancies are resulting in miscarriage. So we're saying 23 million people each year worldwide are affected. And then when we consider the emotional ramifications, they're obviously going to be diverse, but for most people, we all know anyone that's looked after someone in that context, for the majority it's going to be upsetting, really like a significant emotional event in their life that takes some time to get over. But for some, it's going to have a longer term impact or more profound impact and may trigger off more serious or significant mental health problems. And we know from research that's been done with our group that as many as 1 in 3 might meet criteria for moderate to severe psychopathology, including anxiety, depression, and most commonly actually post-traumatic stress disorder. And that can be persistent in the longer term outcomes in as many as 1 in 5. And so then, as you say, if you consider how common miscarriage is, and that's not even taking into account ectopic pregnancies, which obviously is not as common but is going to push those numbers up, you're potentially looking at a huge number of people that are being negatively impacted and that have no real structured support, certainly not in the UK, in place for them in guidelines and in care pathways.
And what do we know about what that means for that woman? You know, if we think about that number of PTSD, you know, 1 in 6 at 9 months from Jessica Farrer's paper, that's a really large number of women potentially in the world. And what does that mean for that woman, for that family, for her, for the society, for work?
Well, we know, I mean, just from general knowledge about mental health problems, that they can have really wide-reaching social and economic impacts. It's really, we're looking at a really sort of unique population because we've got people that are likely to then go and re-expose themselves to that trauma again really quite soon after in the efforts to try and get pregnant with a healthy pregnancy. And we know that most of our patients want to do that, so they're unique in that way. But it also means that we have to consider other impacts. Is there an impact of PTSD on future pregnancies, not just on their mental health, but there is evidence to suggest that people have that pre-existing PTSD have worse mental health outcomes in pregnancy and postnatally, but also it can impact on the physical health of the mother and increase risk for complications for the fetus. So it's not just about how someone's feeling, it can have really broad-reaching impacts, not to mention wider societal impacts and on their families. If you're living with someone that's suffering, then they're not going to be able to fulfill their sort of everyday roles in life in the same way that they would if they weren't.
It's just got such huge implications on every aspect, whether it be, you know, getting on with your day-to-day, your physical health, your emotional health, your well-being, ability to work. It's when we have that, you know, couple in front of us, we often, you know, don't really carefully consider the language we use, and we're not always, you know, using language. We're using very loaded language, often implying guilt or blame on the mother. You know, what are your thoughts on that?
Well, I think, like everything in medicine, when we go to medical school, we learn this whole new language of terminology, and then it becomes expected of us to utilize it, and then it becomes second nature. So despite trying to avoid complex sort of terminology within our interactions with patients in any setting, we all fall into the trap of doing that. So I don't think there's any malintent by anybody, but I think that when you really sort of look at the language that's been historically, the medical terminology around early pregnancy loss as a whole, complications of pregnancy, and actually women's health and fertility, you'll find that it's really sort of connected to and triggering for this feeling of failure and like failed pregnancy, as in the word. Even miscarriage, which we feel is a more sensitive term to use than spontaneous abortion, some people feel implies blame, and that we need to consider is should we be moving away from that. Even the term loss, I don't think there's any like right answer. You will always find that some of the language you use around this is going to feel triggering for some people, but there are clearly some terms that are more sensitive than others, and there are clearly some terms that should never really be used. So I think we all agree that spontaneous abortion is not an appropriate term to be used within an early pregnancy loss setting.
Absolutely.
And carries with it a lot of emotional stigma, that term. So I think we can really consider the language we use. We can echo the language our patients use when they're referring to their pregnancies, and it's it might feel inappropriate to refer to an early pregnancy as a baby for us as clinicians who see an embryo or an empty gestational sac, but for that person that feels like a baby. The language that's used in antenatal clinics when they're being booked at 6-8 weeks is all about the baby that you're going to have, and then as soon as we tell them that pregnancy is no longer continuing, it suddenly becomes very clinical and is no longer a baby. But to that person, it was their potential baby. So I think we just have to be really mindful all of that when we're talking to people. And I think it's not just the terms that we use that are so important, but it's also the way that we deliver them. And sometimes we have to explain what an ectopic pregnancy is or what our concerns are that we're finding on an ultrasound scan, but we can do that in a sensitive way rather than just leaving them to read that we've seen a latex or mass. So I think we have to be able to communicate between each other as clinicians clearly, so that is important. And it may be that sometimes we use slightly different terms between each other than we do with our patients.
It's such an important matter, and it really matters to patients. It's, I think, what they most remember. And I think we often forget that as doctors and clinicians when we're delivering care in any clinical setting. And I guess the other thing that the first trimester, the other layer of this is that the first trimester is kind of shrouded in secrecy. Often this is quite an isolating event for couples.
Yeah, I think a pregnancy in the first trimester is hidden from everybody. It's hidden physically, and then we hide it behind this sort of tradition of not announcing our pregnancies but beyond the 12-week mark in the main. And you're right, I think that leads to people feeling very alone and isolated, and may contribute, it's probably a two-way street, what contributes, what comes one before the other, but those feelings of responsibility, shame, like failure, like they've done something wrong. And there are, I think, despite changes, despite people talking about it, despite celebrities or people in the public eye sharing their experiences of loss, there is a continued sort of stigma around early pregnancy loss and fertility, I think, and obviously there will be differences within different cultures as well. So I think that potentially makes our cohort of women even more vulnerable to these mental health problems, and also potentially less likely to go and seek help.
Absolutely, and I guess being isolated or alone is potentially a risk factor for feeling to developing mental illness. But do you think that there are any risk factors that we can identify to those at risk of developing depression, anxiety, or PTSD? Is there anything that we would, for the woman, for the couple in front of us, that would make us far more concerned?
So you'd think that there would be, that so that you should be able to identify those people that are more likely to suffer. So those who've had previous losses and those who have a previous history of mental health problems were shown in a study by Jessica Farron to have slightly higher chance of going on to develop mental health problems. But the other prognostic factors, and even within those two areas, the area under the curve was not that high, which means that the prognostic value was limited. And so really the conclusion from that paper that was published on this was that actually you have to consider everyone as potentially vulnerable to having this impact, like huge psychological impact, and so we need to really be thinking about strategies and ways that we can identify them after the fact if we can't through looking at risk factors before.
And so leading on from that, does knowing why make a difference? Does that help potentially the impact of loss on psychological well-being?
I think that's a good question. We probably don't have a really hard yes or no answer to it in terms of the amount of research that's been done that can back this up. But there is some data to suggest that if you're investigated, so not even being told why, being given a reason, but just having someone invest in looking into why this might have happened, that you might have lower levels of self-blame. So you might blame yourself less if someone's trying to find out why. And that we know that self-blame has been associated with increased risk of psychopathology in this context. And there has been couple of studies that were done quite a long time ago now that did show that giving people a reason in the main, because of for giving them a result of chromosomal testing, they had lower levels of self-blame, and there's one study that demonstrates that those that were given that reason why and the cause why also then had lower levels of psychopathology than those who not only weren't given a cause, so had the test but also those who weren't investigated. But I think it's important to also consider the potential negative impacts of doing tests to find out why, because we will always have a number of people where we don't find a reason, and it may be then for them that they have worse outcomes, and we really need to drill down and look at that and understand that properly.
We probably need some more studies, really, to help answer
exactly.
that very question. And so then going back to your point that then, sitting in a clinic with a couple and we make the assumption that everybody in our early pregnancy units is at risk, is there a role for screening?
So we think so. Given that we can't identify people through risk factors, given that we also know that just treating everyone doesn't seem to be beneficial, and that's probably because there's a group of people who will just get better on their own. We know not everyone's going to be suffering, that we think that it's important that we find a strategy through screening to identify those who actually need the treatment so they can be targeted appropriately. And that's part of the Lancet Miscarriage Series recommendations, is screening for everyone after their first miscarriage for mental health complications, recognising the potential for that. And we have just started piloting a screening programme and at Imperial, as you know, which is done by text message. So, and we've shown that it's in the main been acceptable to women, with the majority opting in to have that type of follow-up after a loss. And we send them a text in 2 months afterwards, and we ask them to complete a standardized, validated screening tool. And we have found that although the response rate is not huge, around just over a quarter of people responding, what's key is that the majority of those are actually the ones that have got significant levels of psychological distress. And when you then look at the percentage of people that you're sending the text to who have this psychological distress, it echoes what we've seen in the previous studies. Around 1 in 5 people who you sent the screening tool to have got psychological distress. And so it fits with what we know or we would expect, and it seems that this is potentially quite an effective way to reach out to them and offer them appropriate help.
And it's interesting because, we say this 1 in 5 or 1 in 6 from Jessica Farron's data, but these are of the people that responded. And we're talking about the response rates for these kind of psychological screening tools. Do you think there's a chance that there are women out there who are very affected and actually don't respond? A lack of response, it might indicate significant psychopathology?
Yes, I think so. And I think probably the cohort that within the sort of research setting of the looking at prevalence and people being recruited to a study may be slightly different to the group where we're piloting a screening sort of tool within the clinical application outside of sort of a research study. It's sort of service evaluation. And so what we have seen is a lower response rate, but a higher rate of psychological distress. So nearly 70% of those who respond to our screening have been psychologically distressed, compared to Jessica Farron's research study, which showed obviously lower rates. But I think what your point is really important is that it's possible that we are overestimating, but it's also possible that we're underestimating. And what's, I think, likely is that you've got people who are completely fine, who don't bother to respond, and you have also potentially got some people that are so severely affected they can't even engage with anything coming from the outside. And it's really difficult to know how you can deal with that.
Yeah, of course. I mean, it will always be a challenge in any a study, particularly a screening study. And you alluded to if somebody screens positive, you alluded to treatment. What would that look like?
So I think that's a very good question. So part of our screening program that we're doing, we will refer them on to pregnancy loss specific counselling and therapy, and if they have been very severely affected and indicated like suicidal thoughts, then they will be referred to the sort of local emergency mental health team, which will then triage them for effective treatment. But the question really is still out there is of what is the right thing for people after early pregnancy loss in terms of counselling or therapy or treatment. I think for those who are going on to develop specific psychopathologies such as post-traumatic stress disorder or anxiety, we have to follow the evidence for those conditions. And so that would be for PTSD, trauma-focused CBT, or eye movement desensitization reprocessing, EMDR, which are the first-line treatments within general population presenting with PTSD. And similarly, CBT is first-line for depression and anxiety. But looking specifically in the miscarriage population, it's a really underserved population in terms of research. And even when you look at the data that supports those treatments within the general population for those conditions, you will find that women who are pregnant or within 1 year of pregnancy are excluded from all of those studies. And so there is a question of, is it generalizable to the population? We don't know 100%. And in an ideal world, we do a study just in our group. There is quite an old now Cochrane review that looks at early pregnancy follow-up for miscarriage and looks at RCTs. But when you sort of look at the studies that they evaluate, it's are really heterogeneous, sort of how they approach it, who's giving the therapy, what therapy it is. It might be a nurse, a gynecology nurse that's calling them, and it's one session, and it's also in all of those cases being offered to everyone rather than being targeted at people who actually need it. And it concluded that they didn't have evidence to support it. But I think, in my opinion, that study and systematic review has been used almost as an excuse for us to do nothing. And because we can say, oh, look, it doesn't work, so there's no point. But I don't think that's what it shows. It just shows what they've tried to do hasn't worked, and that we need to do something else because there clearly is an issue.
Absolutely. And we go back to that couple in front of you and the patient in front of you. And there's clearly this high risk of psychopathology. And if they screen positive, that has implications and treatment implications. And we talked about the potential impact on their lives, really. But what about work? I mean, we forget that women trying to conceive are often working, and there are different labour laws, there are different laws about sick leave, and what rights do women have? I know you won't know that for every single country, but what should employers really be doing to support women going through pregnancy loss?
So I think there is movement in different places around the world to try and bring in policies or laws to protect leave for people and their partners, to have protected time off, paid leave after an early pregnancy loss, not equivalent to that of a sort of later loss, but not just for women but also for their partners. And in the absence of that, I think within our clinical practice, we can offer people a fit note for work, sick note, whatever it's called within whichever country you are, to try and encourage them to take some time, not just to recover physically but also emotionally. We need to consider employing that as part of our standard care, I think.
It's fascinating, isn't it? Because I'm not sure even healthcare employers do this necessarily as standard.
So I think the NHS has now implemented so in the UK, the National Health Service as an employer has now implemented or is in the process of implementing a policy for 10 days protected paid leave. But it's not just having these policies in place. You need to foster an environment where people feel like they're able to share what they're going through, to access that.
Of course, it's culture, and that is as important as you say, so that women, actually are offered that and feel comfortable to ask for it as well. Absolutely. So, our kind of final message, really, what are the key things that you think clinicians can do better in caring for couples with pregnancy loss?
So I think the first thing that we all need to do is acknowledge what this might mean for them, and be sensitive to the impact that it's going to have. I think we also need to acknowledge to ourselves that we're in quite a powerful position as doctors or as healthcare professionals, in that we can potentially sort of validate how they're feeling, and give them permission, as it were, to take some time from work or to feel like that. But on the flip side, that also means that we're also in quite a powerful position to do the opposite and make people feel worse. So we have to be really sensitive to, as we've already discussed, the language we use, how we communicate, the settings we're seeing these people in, how we follow them up, and not just in the time of that pregnancy loss, but also in subsequent pregnancies. And we all know that we see people who are incredibly anxious, who've had previous losses, who want to access early scans. And it may, for a busy, overworked unit, feel inappropriate to be doing reassurance scans, but actually, for that woman, it might make just all the difference.
Absolutely.
For the patient, we'd be able to see them or have that interaction in person, but it's just not feasible. And I think that for that reason, it doesn't get done by anyone. So we're looking at this way of sending them a text message. And we ask them to complete a questionnaire and give their consent for onwards referral. What we found is that what part of that pathway for women who demonstrate that they've got really severe psychological distress, including having suicidal thoughts and potentially acting on them. We obviously follow them up by speaking to them on the phone and doing risk assessment. And I think we've only been piloting this over 6 months, and we've only had one case such as that. But I think that if this sort of program only really helps one person who's been feeling suicidal and hasn't managed to access mental health support by any other means, then we're providing a service that's really required, and it allows us to get them under the right care to support them. In terms of partners, I think partners are often overlooked in the clinical setting because on the main we're gynecologists, our patients are women. That's how we're trained, and I do think that they are overlooked, and we know that they are also overlooked in research. But there is some evidence to suggest that although the negative psychological impacts may be less than that of the person who has the physical loss, that partners are still impacted, and that the levels of psychopathology are not insignificant in partner groups when you compare post-traumatic stress disorder, anxiety, depression. But if you look at the wider literature, you might see actually that partners might be less likely to have those types of negative psychological reactions, but they are more likely to have other negative psychological reactions, and we might not be asking the right questions when we're doing these studies always to elicit that. And there is evidence to suggest, for example, that they're more likely to take part in compensatory behaviour, so alcohol misuse, substance misuse, see themselves as sort of a supporter role, which can then push them to feeling sort of overlooked and marginalised. And I think that leads nicely into then thinking, well, if you've got a bit of a disparity in response or the roles within that loss, particularly if one of those partners is suffering significantly with anxiety or post-traumatic stress or depression, it's probably not surprising that there is evidence that tells us that there's an increased risk of relationship breakdown. Now, one of my research studies has been following people up after an intervention for women experiencing early pregnancy loss to try and reduce their flashbacks. But one of the questions we asked them on the follow-up at 1 month and 3 months later is, has there been a positive or a negative or no impact on your relationship? And we've given them an opportunity to tell us what that impact is. And I have just looked at this and seen that there's a disparity in response, but they're quite extreme. So there are some people that feel like having this loss brings them closer together because it opens a conversation and they're going through this big event as a couple. And then on the flip side, you have people feeling very distanced because they don't understand each other's responses to the loss and that they are having a very different experience. So we know that we've performed a study that looks at burnout within obstetricians and gynecologists, so not exclusively looking only after early pregnancy patients, but we know that burnout levels within ONG doctors nationally within the UK is incredibly high, and that in our repeated study that we performed in 2022, we had levels overall of over 70% of burnout from respondents. And particularly high in trainees, where it was 80% levels of burnout. And I think that that might not be only down to early pregnancy interactions, but the way that might impact on how these people feel able to care and their ability to provide sensitive and empathetic care to women is going to be impaired, because we know that burnout is associated with lower levels of empathy, impacts quality care, impacts patient outcomes. Not just in the early pregnancy loss, but pregnancy as a whole, women are given a sort of unrealistic view and expectation of what they should experience and want to experience, and we see that on the labour ward, and people wanting particular sort of birth experience and being very wedded to that, even in the presence of having sort of medical risk that means that we should be intervening medically to help achieve a good outcome for them. I think social media can potentially be very useful in being able to disseminate information to a wide variety of people, but it has also probably, in my opinion, been quite harmful in many ways in pregnancy overall, in terms of expectation of a sort of what a normal pregnancy should look like, and what people's expectations are when they see the sort of 2 blue lines on the urine pregnancy test. And I think we still see people in clinic that are just shocked that they could possibly have had a miscarriage and never considered that might happen to them. And so I think disseminating information through lots of different methods into different cultures, different sort of groups, is important. On the flip side, you don't want to make people feel overtly anxious.
Yes, absolutely.
But I think I would always lean towards sort of more information allows you to make your own judgments and can manage your expectations.
I think that's a wonderful place to conclude, and a really useful final message. Thank you so much,
Thank
Nina.
you.
It's been really interesting.